Good morning. This is Lara Asrawi, and I will be presenting the results of our study entitled Determining the Utility of Epithelial Thickness Mapping in Refractive Surgery Evaluations. This was a study conducted by myself and my mentors, Dr. Dupes and Dr. Randleman, and none of us have any financial disclosures related to the work presented. Now, the use of epithelial thickness maps in refractive surgery evaluations has been well demonstrated. This is an example of a patient who might have been offered corneal refractive surgery based on tomographic findings that do not demonstrate any blatant abnormalities. There is a subtle truncated bow tie on anterior curvature, so perhaps this patient might have been offered a less biomechanically destabilizing procedure such as PRK, but this is essentially a patient who would have been offered a corneal refractive procedure based on tomography. But looking at the epithelial thickness map of that same eye on the right, we notice a pattern of central thinning in the same location as the central steepening that is the truncated bow tie on anterior curvature. And so this combination of mild steepening and epithelial thinning compensating for the steepening leads us to believe that there is a mild or early underlying ectatic process going on, and so this patient was ultimately denied corneal refractive surgery. Alternatively, this is a patient with clear inferior steepening on anterior curvature who would have been denied a corneal refractive procedure. But looking at the epithelial thickness map of that eye, we see a pattern of inferior thickening in the same location as the steepening on anterior curvature. And so this patient's steepening is actually explained by epithelial hypertrophy as opposed to an underlying ectatic process, and this patient was ultimately offered a corneal refractive procedure. But how often we actually encounter such cases in clinical practice is still unknown. So the aim of our study was to determine the extent to which epithelial thickness maps impact decision-making in refractive surgery evaluations. To this end, we conducted an evaluation of 100 consecutive patients who were screened for refractive surgery candidacy. 2 masked examiners independently assessed patients' candidacy for each of LASIK, PRK, and SMILE, and these 3 surgeries were ranked from most favorable to least favorable for every patient deemed an eligible candidate for surgery. An initial assessment was made based on patient history, refraction, slit lamp examination findings, and tomography, which included the 4-map refractive display shown earlier, as well as the Bellin-Ambrosio enhanced ectasia display. The examiners were then shown the patient's epithelial thickness maps derived from OCT imaging of the cornea, and a second assessment was made. For each patient, every assessment was made based on an evaluation of both eyes. Changes from assessment 1 to assessment 2 were recorded, and the results were as follows. Candidacy for corneal refractive surgery changed for 14 to 17% of patients. 9 to 10% were screened in for surgery, while 5 to 7% were screened out. The surgery of choice changed for 15 to 16% of patients, and the ranking of surgical procedures from most favorable to least favorable changed for 24 to 26% of patients. 11% of patients gained eligibility for LASIK, which we considered the most biomechanically destabilizing of the procedures offered, and 7 to 8% lost eligibility for LASIK. If you take a look at the p-values in this table, you can see that there was no difference in the change in assessments of both examiners. In conclusion, epithelial thickness maps derived from OCT imaging alter candidacy for corneal refractive surgery, as well as the choice of surgery in a substantial percentage of patients, and are thus a valuable tool for screening evaluations. Overall, the use of epithelial thickness maps results in screening in a slightly larger percentage of patients for corneal refractive surgery. Thank you.